clinical problem solvers. I want to welcome everybody to a special POCUS Tuesday VMR today. We have a very special guest today, Dr. Gigi Liu, who's joining us today to present a case, and co-discussing today will be Dr. Travis Smith, and scribing and teaching points. I guess Promise and Yasmin will be helping out, but before we get underway, I'll ask Dr. Gigi Liu to introduce herself.
Hi, everyone. I'm Gigi Liu. I'm from Johns Hopkins Hospital. I'm a hospitalist. I am currently leading the POCUS education for the internal medicine residency program, and also has been helping at Johns Hopkins Bayview and a couple other regional residency program in the state of Maryland. But look forward to working with you all. This is new for me, and I hope to get some feedback from all of you. Oh, great. I also want to just mention Dr. Gigi Liu is a legend in the ACP Maryland community. She just won this year's Theodore Woodward Award for excellent teaching. So just want to highlight there. We also have Dr. Travis Smith, who's joining us today, who will be co-discussing.
Thanks for having. Happy to be back. For my been away from VMR for a little bit, but happy to see some familiar faces, and hopefully I have some of my LECOM students interested in POCUS and ultrasound in here to combine a little bit of clinical reasoning and ultrasound, to my favorite thing. So let's go.
Okay, then I'll ask Promise and Yasmin to introduce themselves.
Okay, I go first. Hello, everyone. My name is Jasmine. I am a medical graduate from Mexico, and I have an interest in internal medicine. And today I'll be doing teaching points. Now, let's go with you, Promise.
Hi, everyone. My name is Promise. I am a third-year medical student in Chicago, and I'll be doing scribing today.
Awesome. So let's launch the whiteboard and start with the first aliquot.
All right, should I start? Are you ready?
Yes, please.
Okay. Chief complaint is chest pain and shortness of breath. So HPI, 60-year-old gentleman with hypertension, active cocaine use, typical in Baltimore, who presents with 2 days of chest pain without radiation and shortness of breath. After having his inhaled cocaine use. He denies diaphoresis, orthopnea, peripheral edema, weight gain, no nausea, vomiting, abdominal pain, nor headache. Past medical history known for hypertension, as I said, active cocaine use. He also has a mild history of asthma as well.
We can stop there. Travis, you want to tackle this first aliquot?
Yes, certainly. We could split it up, or you do the next one. You want me to do this first one?
Yeah, we could co-discuss these.
Yeah, maybe I'll talk a little bit about the initial symptoms, and then you can piggyback and let me know what you think. So the first thing, I work in emergency medicine, and getting a complaint like chest pain or shortness of breath, my mind always thinks back, and I like to think of schemas. And the first one I think of is the chest pain schema. And, pull up the CP Solvers app, and I'll look at, 4 + 2 + 2. I'm going to look at the cardiac causes like acute coronary syndrome, aortic dissection, tamponade, Takotsubo, the pulmonary causes like PE and pneumothorax, and then the esophageal causes like a ruptured esophagus or a food impaction. A lot of those things you can get initially from the history and what was going on, and you can kind of narrow these things down. But I always think of those at the beginning. Next, the patient also has shortness of breath. And I think, many of us will find two competing symptoms, and we have to decide, what symptom is signal, what symptom is noise, or how we can overlap those and kind of make it a part of, a thought process and an illness script that we can build and put together to kind of, that would require us to ask some more questions about getting information that we need in order to move on with our diagnosis. I feel like with these two symptoms, we can overlay a lot between the two. And I think a lot of these symptoms from, the underlying reason why the patient is there is likely causing both of these. Specifically, when you're getting into what was going on at the time the symptoms started. I think that's really important, and asking questions to the patient about, what were you doing when your shortness of breath started? What were you doing when your chest pain started? What were you doing when your abdominal pain started? I think knowing that will really let you hone in on the diagnosis. The first thing I think of here, I can personally think of a case where I had a young man who came in who was, I think he was in his late 20s, and some friends came into town he hadn't seen in a couple of years, and they did cocaine and marijuana, and he was having chest pain. So I went to my schema. I said, all right, what could cause this? I listened to his chest and I couldn't hear any heart sounds. And I'm like, that's weird. I pressed on his chest and I felt crepitus. And I'm like, that's interesting. I put a POCUS on and I couldn't see anything. It was all air. He ended up having, he was coughing on a closed glottis and had a pneumomediastinum, and that was causing his chest pain. And that was obscuring the POCUS. He also ended up having an elevated troponin level, probably from the cocaine use and some EKG abnormalities. So he actually had two reasons to be having chest pain, the pneumomediastinum, and he also had, cardiac injury from the cocaine, likely from the sympathetic storm that ensued. So sometimes you might go down this and find two things. But, those are my first thoughts when I think of, the chest pain, the shortness of breath, what they're doing. And, I think there's going to be a lot of signal with both of these into finding taking our next steps in diagnosis.
Absolutely. I just love the emergency room approach. And like you had mentioned, the highlighting, what's at the center of gravity here. Is it the cardiac system, or are we in the domain of the pulmonary system? Because both of them can actually present as chest pain and also shortness of breath. But I can't help but prioritize the cardiac system at this point. As Travis had mentioned, first you want to at least rule out ACS being one of the life-threatening causes. So getting an EKG troponin is crucial at that stage. Even in spite of the primary assessment by emergency room, many times these things can get worse throughout the time, or where it could ramp up and manifest with acute coronary syndrome. But what I can't help but look at is the use of cocaine. Is cocaine something that can precipitate this, or is just another maybe something in the social or health-related behaviors that could be a red flag, or could be something that we should not prioritize? But yes, if we do prioritize this, as mentioned in the chat, Yasmin mentioned it can cause vasospasm. It can also increase the sympathomimetic effect, like Travis had mentioned, increase heart rate, increase myocardial oxygen demand. But there's also an interesting association with cocaine use that in situ can also be a prothrombotic agent. So putting all that together, increased heart rate, blood pressure, vasospasm, and then clot formation, you can end up having a tremendous myocardial infarction. Other things like Travis had mentioned, using cocaine, opioids, opioid withdrawals, Narcan use can precipitate non-cardiogenic pulmonary edema. Regarding the pneumomediastinum, I wasn't aware of that, but every time you come to CPS VMR, you always learn something different and unusual. Asthma in the past medical history, exacerbation could potentially cause chest pain or the sensation of chest pain. An exacerbation, you have predominantly wheezing, shortness of breath, tachypnea, hypoxemia. But at this, we don't really get a lot of signal for that. So I probably wouldn't highlight that. No diaphoresis or orthopnea, those could go hand in hand with acute coronary syndrome. You have sympathetic surge, you have diaphoresis, you may have nausea, you may have other associated features that carry along with the ACS. But at this point, I definitely would want to get more data and see what that EKG shows, what the cardiac enzyme shows, then what the POCUS shows as well. So back to you, Gigi. Gigi, you're muted.
Love the discussion, and I love what's going on chat. We'll see how this goes. All right, so I'll go finish off the past medical history, hypertension, asthma. Medication, he has not been taking any meds. Family history, mother, father, and his 2 daughters have hypertension. Father with also diabetes and asthma as well. And then social history, former smoker, of 25 pack a year, quit 5 years ago. Besides cocaine, he has not been using any other illicit drugs. Currently unemployed, former housekeeper. All right. No known allergies. Should I keep on going?
Yeah, maybe go into and give us the physical exam, and then we can break that down.
Sure, I'll start with the vital signs first, and then the physical exam is going to be audio-visual. Temperature is 96.0, heart rate of 90, blood pressure of 180/70, respiratory 18, O2 stat of 97% of room air, BMI of 40. As I mentioned, not on any medication at all, so not on any beta blocker. All right, so let me try to then, next is for the physical exam, which is what I wanted to actually share. Give me 1 second. So if I can share my, can I share my, yes, I want to share my screen. And then I also want to share my audio and see, hopefully this is going to work. Can you all see?
Yes.
Okay, and then I guess, let me see if I can. So first of all, I want you to take now, when you look at the JVP, when you look at the neck, this is what they see. Can you all see the video?
Yeah, we can see it.
Yes.
Okay. So just look at that neck. And then the diagram all the way to the other side is that the PMI is where the red dot is located. Okay. Ready to move on to the next physical exam finding? All right. Can you all hear the audio?
Yes.
So the top part, let me just pause for a second. So top part is a carotid pulse so that you can time the S1, S2. The bottom part, I'm being nice and showing the phonographic visualization. The axes are where we put the stethoscope and where we hear the murmurs at, okay? Let me repeat again one more time. Okay, are we ready to go for the next one?
Yes, please.
Okay, this is the last audio. And the X is where we hear this extra murmur, and the phonographic visualization hopefully help you guys out in terms of what we're dealing with. Okay, and then the rest of the exam for the lung is pretty much symmetric lung expansion, cleaver auscultation, no crackles, no wheezes, no rows. Abdomen, no pulsatile liver, only mild tenderness in the middle abdomen area, no guarding, no rebound, no organomegaly. And then for the extremities, prominent radial and distal pulses bilaterally, no edema, clubbing, or cyanosis. So I can stop the sharing.
Sure, we can bring the whiteboard back up. Travis, do you want to take a stab at that?
Yeah, so maybe I can talk about all the normal things, and I'll throw back to you the abnormal things. So, taking the HPI and his past medical history, we have a 60-year-old former smoker who has hypertension, who presents with chest pain and shortness of breath at rest. Certain features that we ask, what were you doing when it started? Was it at rest? Did the pain radiate to your back, to either arm, or both? Asking those questions raises our suspicion and increases the likelihood ratio for, aortic dissection with the radiation to the back, or the acute coronary syndrome for pain that radiates to one arm or both, or to the jaw. But if they don't have those things, that doesn't rule it out. It might just lower it down on our differential a little bit. So I just wanted to make that a point. Just because something doesn't fit a classic picture, that doesn't mean that it can't be that diagnosis. No vomiting. I think getting someone who has chest pain or shortness of breath and they're vomiting, I think, that and diaphoresis definitely increases the likelihood ratio for acute coronary syndrome. Adding on the fact, that he is using cocaine, tells me that I am concerned for acute coronary syndrome, a dissection, and Takotsubo. Anything that, I know Takotsubo is more common in females, people under stress, but I think anything that can increase that sympathetic drive can give you that. And I think one of the reasons for the findings you see on echocardiogram are the distribution of the alpha beta receptors in the heart. And I think females have a more predominant concentration, I want to say, of beta 1 receptors in the apex of the heart versus men. And I think Tony Brew or somebody did a tutorial on it. So I take that from the history, and I'm going to first kind of focus on his heart and lung exam and his neck, and looking at JVD, and I'll have Dr. Singh talk about that. Certain things that I'm not hearing is, I'm not hearing crackles. I'm not hearing, I'm not seeing pedal edema. So I'm looking like, hey, is this guy third spacing? Is there evidence of heart failure that jumps out at me? And I'm not seeing that. That doesn't mean he's not in heart failure. Maybe he has a big obese abdomen. I want to say, what was his BMI? 40. If he's got a big abdomen, he might be third spacing there and not in his lower extremity. So it's still possible, but less likely. Also knowing that someone who smokes and who's 60 and who is short of breath can also have COPD. So not hearing wheezes decreases the likelihood, but it could be very diminished. And maybe giving him a nebulizer might open him up, and I might be able to hear a sonorous wheeze or wheezing in general, but I don't hear that. So I'm less thinking a pulmonary cause. And then, as far as the organomegaly part, I mean, at a BMI of 40, it's going to be hard to palpate organomegaly. I'll take that for what it's worth. Just because I don't feel it doesn't mean it's not there. A POCUS would be a great way to see if there's any organomegaly, measuring the liver and the spleen. And, he's got some mild abdominal tenderness in the mid abdomen. Hard to make what to take from that, depending on, if it's epigastric pain and that's reflection of the, inferior aspect of the heart, or it's something, more up top, like his pancreas or stomach, or something that's higher up that could be causing pain in the thorax. And, his symptom might just be all up here when his really pathology is in the upper abdomen. So I'm still thinking about that. And the pulses part, checking pulses, knowing that they're equal, tells me that, hey, maybe there's not a big dissection that's tearing through a subclavian or something like that. The pulses are bounding. So those are the kind of things I think of when I'm looking at, when I find normal findings and what I'm going to be kind of marking down on my likelihood ratio to my final, diagnosis or what imaging I'm going to take next. But I'll throw it back to you, Dr. Singh, if you wanted to go over some of the pertinent positives that were there.
Sure. Great job there, Travis. Definitely aortic dissection comes into mind with something like this. Just scrolling through the vital signs, picking off patients say febrile, their heart rate is near the upper limit of normal, no beta blockers. I think Ria had highlighted if the patient's taking cocaine, you'd expect the heart rate to be up into above 100. But the blood pressure is very interesting. A couple of the colleagues in the chat mentioned there's a wide pulse pressure. So you see the systolic is exaggerated, diastolic is within normal range. So that difference is remarkable and astonishing. And when you have wide pulse pressure, you can't help but think of things like there could be physiologic causes. Athletes may have this wide pulse pressure. Valvular disorders, aortic regurg comes to mind. There could also be hypovolemia, intravascular issues such as anemia, volume depletion, iron deficiency could cause it. But then there's these hyperdynamic states. I think Rafa mentioned in the chat, you could have sepsis, you could have beriberi, you could have obesity, cirrhosis, and other conditions that could cause this hyperdynamic state. But here, what's interesting, I love that Gigi showed us the physical exam. First of all, the murmur, highlighting the murmur. Where exactly was the murmur? It was within the diastolic range of the cardiac cycle. So what diastolic murmurs do we think about? Aortic regurg, mitral stenosis comes to mind. And with the picture that she showed where exactly the murmur was accentuated was left lateral sternal border. And what comes to mind in that area we should think about is aortic regurgitation. Then there was also a remarkable finding that the pulses in the lower extremities were exaggerated. And commonly associated with aortic regurg is the Corrigan's water hammer pulse. So those can fit what was found on the physical examination. And then what Travis did was take that and start thinking about or probing why is this patient developing over 2 days, but this process could be bubbling under the surface. Why is this patient developing such a devastating valvular pathology? So aortic regurg comes to mind again. Aortic dissection comes to mind, and that's something I would worry about in this patient. Any other thoughts, Travis, before we go on?
No, I think all of what you said and bringing and highlighting those abnormalities, I'm going to think of, hey, what test do I want here? I want an EKG. Okay, that's one thing that's going to tell me what is actually going on. Does he have any evidence of ischemia on his ECG? And overall, does he have anything underlying that's predisposing him, to having some sort of event? Looking for bundle branch blocks, conduction delays, and I'm thinking right now, what therapy do I need to be giving this gentleman? Probably what I'm going to want to get him, if I'm thinking dissection, I'm going to be, reaching for a beta blocker, maybe putting him on an esmolol drip, depending on how long it takes pharmacy to get that for us. If I wasn't thinking that, I would be going for, nitroglycerin and starting him on a drip, or even nicardipine drip. I think all those things are good. Starting with like a 0.4 milligram of nitroglycerin to see if that helps. And if that helps and my nitro drip is delayed, I can just give them 2. But all depending on where you work, if you have an ER pharmacist or not, having something handy to kind of augment his blood pressure to improve his symptoms. I necessarily wouldn't be giving him oxygen, because his O2 saturation is 97%. I know we were all taught, Mona, give everyone oxygen. I would probably give him morphine. I probably would withhold Toradol, just knowing if it's a dissection. But I probably would give him 4 morphine, give him a nitroglycerin, and then, go into discussing what we want to order lab-wise.
May I chime in a little bit? So those are great discussion. I really am very excited that many of you picked up some of the physical exam finding. So the carotid pulse is definitely the Corrigan pulse. The diastolic murmur, as Dr. Singh mentioned, definitely were heard. There's actually a little bit of systolic murmur as well. And then the murmur at the apex is actually the Austrian fluent murmur. We can discuss the pathophysiology down the road, but you all at least picked up most of the important find, and then the prominent pulses of radial and distal pulses too. So all of those definitely are pointing toward concern for aortic regurgitation, which I think you guys are all figuring this out. So I'm going to dive into the rest of the data, and then we can dive into some POCUS. So white count is 8.85, hemoglobin 12.2, hematocrit 38.8. MCV is 90, platelets 157. None of these are really super remarkable. The chemistry is all normal except with a creatinine of 1.7. AST, ALT, alphas, Billy, all normal as well. Troponin of 0.06, lactate of 1.2. And then EKG, some of you were mentioning, sinus actually, and no ST2A changes. I don't have a picture to show, but nothing crazily remarkable. Baseline creatinine, we don't know. This is the first time a patient comes in, but it is a increase of creatinine. It is a 1.7, which is not normal.
Guess we can stop here for a second just to discuss the labs. But I just want to ask, Gigi, was that when you showed the carotid pulse, was that, what do you call the pulses, Bisferien's pulse?
The Corrigan pulse.
Corrigan pulse, okay. So it had two peaks. Sometimes we do see with AR this Bisferien's pulse that we get with two peaks, but I guess that is the Corrigan's pulse.
Yeah, the Corrigan pulse. Yep.
Tackling,
yep, sorry.
Go ahead,
and this patient had this patient had the water hammer pulse. I cannot show it on the video, but yes, the prominent pulse was kind of hinting to the possible the water hammer too.
Okay. Just tackling the labs here, nothing significant if we're thinking if there was say acute bleed. The hemoglobin is 12.2, so there is some anemia, probably anemia of chronic disease. The MCV is 90, platelets are 157. So everything's normal here. Chemistry. What is jumping out is this creatinine. So the creatinine for 60-year-old, this could be, prior to even thinking this is an acute increase, could this be part of a chronic kidney disease in its past history? But we don't have anything in the past medical history that signals history of chronic kidney disease. So could this be associated with the current issue at hand? So with going back to one of our major thoughts here, a prominent hypothesis, aortic dissection can dissect into the renal vessels. So could this be secondary to that? So that's something to keep in mind. Lactate is 1.2, so patient is perfusing appropriately. Lactate can also increase in sepsis with bacterial components like lipopolysaccharide can cause mitochondrial dysfunction, and lactate dehydrogenase does become pyruvate dehydrogenase. So lactate accumulates in a septic condition, but in this case, we don't have to worry about sepsis at this stage. Troponin's normal, but then the first troponin always can be normal, but as indicated before, this can ramp up. So you always have to follow with additional troponin, sinus, unremarkable rate loss, I guess 90. So it doesn't help us at this stage, but I would always repeat another EKG. Chest x-ray is interesting. Do we need to get a chest x-ray? We're still thinking aortic dissection, aortic aneurysm. Do we always look for the widened mediastinum? But that's not always helpful. We always have trouble trying to interpret that. But I would actually go for POCUS at this stage, because this is POCUS VMR, to see if that helps in moving the needle forward in our clinical reasoning. Travis?
No, I think one of the things that you mentioned about needing a chest x-ray before certain tests and exams is always interesting, because I remember back in residency, we had an attending where we would get STEMI cases, and just like you mentioned, patient could be coming in with an obvious, STEMI, and their first troponin is negative, right? And the next one you get an hour or two later is going to be positive. So don't ever let that kind of dissuade you from, ruling that out, depending on when the time course of the chest pain started. If it starts within 2 hours of that troponin, it's probably going to be normal. But one of our attendings would never let the patient go to the cath lab before he got a chest x-ray to look for, some kind of obvious abnormality on the chest x-ray. You could debate back and forth whether you need that. I mean, certainly going to a heart cath, you can see the cardiologist is gonna be able to see a dissection on when he's doing his study. So, whether or not your institution wants it before or after, I mean, I think that's a clinical debate to have. But for the most part, when I have someone who comes in with an obvious STEMI, they don't necessarily have to have a chest x-ray if cath lab's coming down to taking them and it's obvious. But yeah, having the EKG being unremarkable, makes me think less of Takotsubo. It makes me think less of acute coronary syndrome, even though EKGs aren't 100% sensitive for these things. I mean, they're probably in the upper 80s, I want to say. I did share in the chat a cool little article on does this patient have aortic regurgitation? If you guys had an interest in looking at that, and one of the useful findings it said is the most useful finding for ruling in AR is the presence of an early diastolic murmur. It's got a positive likelihood ratio of 8.8. And the most useful finding to rule out AR is the absence of that murmur, and that likelihood ratio, negative LR, is about 0.2. So it's a good article. Take a look. It's in the chat, and I'll post it on Twitter as well. And I definitely agree. I would, ultrasound, take a look at the heart, take a look at the lungs, and see if you can't, use the cool features like M mode and Doppler to see, hopefully what we're going to find here.
I just want to add something while you were talking through or discussing some of these points, Travis. What kind of came to mind with EKG is if this is an acute AR that we're dealing with, or something that's devastating, it's not the primary issue, but secondary to something that's going on. But with long-standing AR, you tend to see on EKG at least compensatory measures from the left side of the heart. So I would look for LVH long-standing, but here we don't see any LVH here. So that also heightens the suspicion of an acute process. And going back to the HPI, this happened over 2 days. So if we're seeing this patient in the emergency room, I think this is something that will be putting the patient in jeopardy. And again, going through the motions, like you said, repeating EKG, troponins, getting the X-ray. But if you have a POCUS in your right or left hand, it's very easy to do an acute evaluation right there at the bedside. Back to you, Gigi.
Awesome. So I know they were mentioning about looking at the heart and the lung, but I actually want to challenge this group. I purposely am going to show image without Doppler. It's purposely done because we already kind of see that we already from a physical exam know there's some sort of like a, valvular pathology. And I want to encourage people to not think that they have to use all those crazy gadgets of measurements and everything else to have POCUS be a useful tool in your clinical pocket. Even some very basic knowledge can help you further advance care. So I want to challenge this group to think, besides the heart and the lung, where else would you want to take a look, given that you're highly thinking about AR? I want to see if anyone have any thoughts. If not, I can start up with showing the cardiac too. Suprasternal, okay. You're getting right there. I'm going to tell you right now, yes, that would be one. That's a very advanced view. But let's just think even a little bit simpler. There's one other part in your body that you could also look at. That might help you clinch as to what might be going on with this patient, besides the heart and the lung. That's right. Promise is right. It's abdomen. What would the group want to look at in an abdomen? Pretty obvious, I hope. Yeah, the abdominal aorta. That's right. That's right. So let's dive into the images. So what I'm trying to get at here is that while all the fancy gadget can give you a lot of information, there are actually a lot of pitfall in the Doppler itself. But in this case, our physical exam is actually quite strong. But what we want to figure out, which a lot of you already have discussed, is the etiology of this AR. And so which is what I hope the group is going to go into looking into it, not necessarily look at the murmur, like the regurgitation, but to look at the etiology of what's causing it. And that part, amazingly, does not require fancy gadgets. So let me share the screen now. Can you all see the image?
Yes.
Okay. Awesome. So for those who might not know, may not have a lot of knowledge in POCUS, I'll orient you a little bit. This is actually a parasternal long axis view. We are look at the parasternal long axis view. You basically put the probe with the indicator pointing around 11 o'clock or so, anywhere along the 2nd to 5th intercostal space to the left side of the sternum. You're mostly seeing the left side of the heart and only a little bit of RVOT. I'm going to just orient the group with the anatomy. This is the descending aorta. This is a left atrium. This is a mitral valve. This is a left ventricle. The left ventricular outflow tract right here. And then the aortic valve, aortic outflow tract, and then the RVOT. Will you all be able to see my pointer? Okay. All right.
Yes.
So, there are three major things folks want to look into. I know last time with the last group, you all focus a lot on the pericardial and pleural effusion. I'm going to focus on the two other aspects, the LV systolic function, which we can talk about it. Maybe that's not as important to me as the rules of third. The rules of third is as indicated. I'm going to show the next slide first and then go back to it. Is that the RVOT, the aortic outflow tract, and the LA, that distance that is highlighted in the red bracket here should be all equals in size. If any of them look bigger than the other, then you start thinking something. Those areas might have some dilation there. So now I'm going back to this clip. Are there certain areas, which part, the RVOT, aortic outflow tract, or LA looks a little bigger or bigger than the others? So I want to tell you, so RVOT definitely looks small, right? One could say that LA looks a little bit big, and that the aortic outflow tract would also look a little bit big, and that the RVOT definitely is smaller. And so given the fact that all of you were all thinking about AR, and I'm very glad that all of you have, some of you have already started thinking about potential dissection, the fact that there's a dilation, or at least suggestive of dilation in the aortic outflow tract is concerning, because that would fit the aortic regurgitation that we're hearing on the exam. The one other thing that I want to mention is this descending aorta. I know not many of you see look at a lot of ultrasound, but for those who might have seen a lot of ultrasound, I hope you realize that this descending aorta is actually huge. So I actually measure the size. It's exactly at 4 centimeters, which is at the borderline of what is supposed to be a normal size. So this is actually huge. So this is a case I actually was doing the bedside teaching for. I saw this and concerning for maybe dilation either at the LA, the aortic outflow tract, and I started looking into it more. So I'm gonna skip so this is the parasternal short axis view. This is where when you have the indicator rotate from the 11 o'clock to 90 degree, usually around 2 o'clock-ish, along that in the same spot. And we are looking at the middle part of the ventricle, the mid-ventricle level. These extra, I kind of call the pap muscle ears, are the papillary muscles. And here, I want to point out to the fact that the RV is not big. There's no, the septum is not flat, suggestive of any right side cardiac issue, which is part of the reason I get this view. The other reason is to look at the LV systolic function. And if you imagine a dot in the middle of the circle here, see how all the walls are coming toward the middle of the circle, for the most part evenly, and the black area reduced by at least a third. This looks actually pretty normal. I'll just show you next slide of, imagine dot in the middle and imagine all the walls coming toward the middle here. The area reduced at least by a third, if not half, would be suggestive of like a normal LV systolic function. So at least those two views let us know, okay, there's the descending aorta looks big, the aortic outflow tract looks kind of big, the LA looks big too, but the LV systolic function is okay. And I think all of you can tell based on previous episode that there's no pericardial effusion. So not the best apical fold view, but I'm not going to dive into too much other than the fact that the right side is not dilated. This is just to orient folks. This is the apical fold view in which a probe is put at the apex. I know the view may not be perfect, but this is the right atrium, the right ventricle, the left atrium, and the left ventricle. You have the mitral valve here that's seen more clearly. The tricuspid valve is not seen as clear. I know the wall might not be maybe partially covered, but at least I'm not seeing a gigantic RV dilation. So all I care about in this view, I purposely not put any color Doppler here, is that I'm mostly worried about the left side of the heart of anything wrong. There's nothing on the right that I have to worry about. I can take that off the equation. So this is just a quick slide to show you that the RV size should be about 2/3 or less compared to the left. And you can see that at the apex, the RV apex should be more triangular and occupy only 1/3 of that whole entire apex area. Moderate dilation is if those apex are sharing, almost 1-to-1 ratio. And then severe dilation obviously is the RV size is way bigger than the left, and that the apex now is predominantly dominated by the RV. So in our case, we're more in that normal range here. All right. I'm going to skip the subcostal view and not contributing all that much. So this is the IVC. I can tell this is the IVC because we see a vessel going into the right atrium. You have your liver tissue here, liver tissue on both sides. So we know it's IVC kind of slit in between the liver, for the lack of better terms, in the ultrasound work. It is dilated and it doesn't collapse, has less than 50% collapsibility. I'm not going to use this right now to tell me volume status because the rest of my physical exam does not jive into this. This we'll have to investigate more as to why this IVC dilated. But in this case, it's actually not helping me all that much. And so then some of you were wanting to look at the abdominal aorta. So we're going to dive into that now. So just before I dive into it, this is actually a good teaching point. IVC versus abdominal aorta. So if you learn nothing about AR dissection or whatever, one of the main, or even peritoneal long axis, if you can differentiate between IVC abdominal aorta, you are like way far ahead in terms of anyone knowing POCUS. Folks have always confused those two structures. So the IVC should go in between the liver. It should go into the right atrium. Occasionally, you see the hepatic vein joining to the IVC. The abdominal aorta, which we're going to see next, is going to be outside the liver. You should see spine below the abdominal aorta. It goes outside of the heart. And it might have extra takeoff like celiac artery and SMA. Do not rely on pulsatility or the thickness of the wall to determine whether you're dealing with abdominal aorta or IVC. The reason is that if there's a differences, if there are changes in hemodynamic conditions for the patient, it may not pulsate out as much. Or if someone is super hypervolemic hypovolemic, the pulsatility of the abdominal aorta may transmit into the IVC, making the IVC look pulsatile. So anatomy wins in ultrasound. So use anatomy to figure out structure and not the pulsatility or the thickness of the wall. So now we're going to take a look at the abdominal aorta. So once again, this vessel outside the liver, okay, maybe not as clean, but there's a one takeoff here. And then there's another takeoff right here. So the first takeoff, the smaller one, is the celiac. The second bigger takeoff right after it, this one vessel right here, is going to be the SMA. I'm hoping, and we'll see more better view, I'm hoping you see this hyperechoic line across here. Okay. Concerning for dissection. So one view equal to no view. So this is this really faint white line here. One view equal to no view. So we're going to now that we look at the long axis of abdominal aorta, we're going to look at the short axis of abdominal aorta. I'm going to rotate the probe. And so now this is liver. A little bit not as clean, but this is the IVC. And this bigger vessel here, circle here, is abdominal aorta. The black space down below would have been the spine. And I'm hoping you see a white line right all the way across this abdominal aorta. Okay. This is an interesting view. This is when I was actually attempting to do the apical 4, but I did not tilt the probe enough to get all 4 chamber, and then I caught catching the abdominal aorta with a dissection right here. So I think those are the ultrasound image I want to show. You're all correct that the dissection certainly contribute to the aortic regurgitation. And I'll let the Ravi and Travis to kind of bring it all home together.
Wow, Gigi, that was absolutely incredible. I just love those images, of the teaching was just out of this world. I just appreciate you bringing all of that to CPS VMR today, and definitely for our learners. You never know how you may inspire one of our learners if they use POCUS to maybe save a patient. So these downstream effects are just tremendous, and a lot of times these examinations by the bedside can help rapidly diagnose a patient in jeopardy. But yeah, fantastic. Yeah, the aortic regurg. We were with initially starting out with, say, cocaine on board, chest pain. We can't help but think about cocaine associated chest pain and ACS and all of the other ramifications of cocaine use. But this just did a total 180 degrees. That we have to consider, like Travis used the 4+2+2. It really does work, and Rafa can tell you that as well. In simulation, we did a simulation together, and chest pain definitely was helped by using that schema. But with this patient, the valvulopathy definitely helped us to narrow down our focus to this phenomena there, and then to look into the abdomen was very important to see or track down this abnormality extending into the abdomen, especially the creatinine being abnormal does signal that aortic dissection may be in the region of the renal vessels. Were you able? I have one question to you. Were you able to see aortic dissection extending up to the thorax?
I did. So I was able to. I did not save the clip of the suprasternal view, but I was able to see it. And then I can share with you right now the CT scan.
Oh, great. Yeah, that'd be great.
Yeah. So let me show you the CT scan. Okay. How come? These are all lung. The lung is not as contributory. come on, go back there. Give me 1 second. Okay, so let me play this. So cutting from the sagittal view. Now do my best to point out. So now it's coming from the left side to the right. You see a little bit of LV there. The aortic arch, you see a dissection here, 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 all the way down. I look at Yasmin, she's covering her mouth. All the way down, spiral dissection all the way from, is type A and B, which absolutely right, explain the creatinine, explain, and I mean, we're lucky to be able to see the dissection in the abdominal aorta because there could be an absence of that dissection in the abdomen, and if you just have type A, then you wouldn't see it. But for this patient, he has dissection all the way down. Here, 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 all the way down. And you're also right that this patient end up needing to have a renal artery stent placement as well as a result of this.
Absolutely incredible. I didn't even know the extent of this dissection, but that's like a mega aortic dissection that he manifested with. And again, I just want to highlight those incredible teaching points about looking at the D sign, flattening of the interventricular septum, ruling out. So I had a patient like this that complained of abdominal pain, chest pain. It was extending down. So aortic dissection comes to mind. And I used POCUS in that manner. There was no flap that I could see, but I also want to follow up with a CT. But as you well know, Travis and Gigi, that CTs do take some time to order and obtain and get read. So using a POCUS at the bedside, you can rapidly discern if there is something going on there. So this patient didn't have anything abnormal on the point of care ultrasound. PE was also in the differential. Didn't see any RV ballooning or septal shift. So ACS, I was back in the domain of ACS for this patient. And by the 8th EKG and the 4th troponin, everything was positive, highlighting ACS. So these were very useful teaching points that I'm going to take away from this case. Travis, any reflections or last words before teaching points?
Yeah, you know, I think of aortic dissection. It's the chest pain and syndrome, you know, chest pain and neck pain if it's dissecting up, chest pain and a neurological symptom, chest pain and arm pain, chest pain and back pain, chest pain and abdominal pain, chest pain and leg pain, depending on where it's dissecting down. So, you know, one of the things that I think of is the chest pain and syndrome, you know, and also, you know, contrast his, you know, he had his renal function was abnormal. But just know this, you know, this is my take on it, and maybe I'm out in left field, but, you know, contrast-induced nephropathy, venous contrast-induced nephropathy. I will tell you this, that it does not exist these days. A lot of this is old data from a hyperosmolar contrast through case reports, and the data we have now does not suggest it. And multiple nephrologists, radiology groups, their position, if the patient needs a contrast exam, they get the contrast exam. It doesn't matter what their creatinine is. So this guy, I don't, you know, if you're concerned for it, you can order it before their renal function comes back. You know, this might be a fight at a hospital with your radiologist and everything like that. But, you know, I've done these at my hospital systems, and, you know, this isn't an issue anymore. If they need the exam, they get the exam. But the images were awesome. Correlating the cardiac exam with the POCUS exam, and, you know, just knowing that I don't expect anyone who's just a novice at this to get the images that Dr. Liu got. I mean, those are very good images, and just to be able to see the dissection there, you know, do as many normals as you can, and before you know it, you'll start picking stuff up. So it's just practice, practice, practice.
So I want to answer some questions out there. Some of the questions out there. So what happened to this patient? So let me tell you the background of the story. So this patient was billed to actually come from the ED. come to the floor, billed for cocaine chest pain with hypertension urgency, admitted to the floor for blood pressure control. And then when our team evaluated the patient at the bedside, see all the stuff, it was like a stat CT surgery, stat CT scan, go straight to the CT ICU for a small drip. And then in 12 hours, got the surgical repair. So yeah,
what
so
did
this
they talk
patient,
about his beta blocker when, you know, the cocaine, there's a lot of dogma about using a beta blocker and cocaine. I think some places are good with using it. What was the take at your institution?
I think we are not as dogmatic to the whole beta blocker with cocaine at my institution. And in his case, we need to control his blood pressure. Of course, the vital sign gave you was on, like, you know, upon arriving the floor. Of course, by the time our team round, pressure was a little bit better, but still not good enough given the concern that we have. And so we shipped this, like we immediately bring this patient to the ICU setting, get blood pressure control, and then the patient had the surgical repair. So, you know, I think like we did not expect to see this dissection. Dissection is not a common diagnosis on an inpatient floor setting. It's more of an ED kind of thing. And so when our team did the POCUS, we were looking at the partial lung looks kind of funny. And then the dilated descending, the huge descending aorta looks kind of weird. And then it was during my, you know, accidentally catching the descending aorta at the bad apical fold view that then tipped me off into looking at the abdominal aorta as well, and also saw all the dissection.
Well, incredible. The patient was lucky to have you on board, Gigi, to figure that out. The time is of the essence, so definitely getting this patient diagnosed and into a critical setting is important. So we'll go through teaching points now to wrap it all up.
So teaching point, for chest pain, we start with the CP solvers schema with 4 + 2 + 2, and which is the cardiac issues would be the acute coronary syndrome, aortic dissection, tamponade, Takotsubo, pulmonary, which was pulmonary embolism, pneumothorax, and esophageal rupture and infarction. Then we went to how cocaine affects the cardiovascular system to increase sympathetic tone, catecholamine levels, how it increases heart rate, blood pressure, myocardial contractility, all of which increase myocardial oxygen demand, and how it causes as well coronary vasoconstriction, Haynes thrombosis, and how might exceed, how the oxygen demand might exceed the myocardial oxygen supply, leading to ischemia and infarction. And we cannot forget that cocaine affects cardiac myocytes directly, blocking sodium channels, which decreases left ventricular contractility, and it's also rhythmogenic. Some exploration pearls present in these patients were the water hammer pulse, which is a bounding pulse with a rapid upstroke, followed by a prompt collapse of the vessel due to this rapid and large stroke volume ejection, and commonly associated with aortic regurgitation, and referred to as Corrigan pulse when present in the carotid artery. Now, moving on to the POCUS, especially for aortic dissection, we have to explore thoroughly, I'm sorry if I didn't say that word correctly, anterior chest, back, interscapular, neck, jaw, abdomen, and periumbilical area. Now, when assessing with POCUS, it's very important to remember when differentiating between inferior vena cava and abdominal aorta, do not rely on pulsatility nor wall thickness for identification, rely on anatomy. And here are some very good points that I got from the presentation. The slit in between the liver for the inferior vena cava and the outside of the liver for abdominal aorta, among other points. And remember always the common etiology for aortic dissection would be hypertension, which is the most common, but also the use of amphetamines and cocaine in this patient due to an associated rapid increase in blood pressure. And this would be all the teaching points for today. This was an amazing case. Thank you, Dr. Gigi, Dr. Ria, Dr. Travis, Dr. Ravi, and thank you all.
Thank you, Yasmin. Absolutely on fire with the teaching points. And just to wrap it up, thank you, Travis, for co-discussing. And thank you, Gigi. You knocked it out of the ballpark. Fantastic case and images. And the teaching was out of this world. So appreciate you coming on today. Everybody, have a great rest of the Tuesday. Take care. See you tomorrow.
Bye, everybody. Thanks.
Bye.
Thank you, everybody.